My name is Christina Nappertag, and I head up the KIPL Institute for Physician Leadership with the North Carolina Medical Society Foundation. And with me today, I have my colleague and partner in crime, Aubrey Cuthbertson, as well as Franklin Walker, who is the moderator for the sessions, as always. Today, we will hear from guests from the North Carolina Medical Board, and we will talk about what steps they have taken since to support the state's decision for the response to COVID-19. Our guests today include Dr. Bryant Murphy, who is the board president. We also have Thom Mansfield, who is the chief legal officer, Evelyn, who is the chief communications officer, as well as Marcus Jimison, who is the senior staff attorney. As always, I just want to take a moment to remind you of what the purpose of the Power Hours are. And Power Hours came about as a way to keep focusing on conversation and collaboration and build community, in particular during these times that we have been experiencing for the last few months almost. As such, this forum aims to provide a forum for you for ongoing conversation and to foster collaboration and community. A few of our logistics: if you have any questions or want to chime in on the conversation, please feel free to unmute yourself. We will keep you muted, but feel free to unmute yourself and ask the question or comment. Or you can also put the question in the chat box, and we will get to that as soon as the conversation allows for that. This is also a recorded session, as always, and we will be able to listen to the recording beginning early next week, as always on the KIPL Institute for Physician Leadership landing page that you can find that recording. With that, thank you so much for being here today. Thank you to our guests for taking the time to be here today, and I'm going to hand it over to Bryant.
Thanks, Tina. Welcome, everybody, to I think this is our 6th Power Hour. And welcome panelists from the North Carolina Medical Board. So I want to jump right in with our first question for Dr. Murphy. And before we get into a lot of COVID-19 questions, could you give us a background, Dr. Murphy, on some of the background, the vision, the direction, and what the focus is for the North Carolina Medical Board?
Sure, and thank you very much again for the invitation. Obviously very happy to be here and talk to your staff and the colleagues and licensees from around the state. The medical board has as their mission just the overall protection for the patients of the state of North Carolina. And obviously during this very challenging time, we've had some changes just internally in our processes and the way we do things, but our overall mission to protect the patients and the citizens of the state during this time has remained unchanged. The thing that I really want to also mention is that we've also served during this time to also be a resource for our licensees. So whether it's our physicians or nurse practitioners or PAs, we really want to also during this time be just a source of resource and assistance in addition to our regular mission of licensing and discipline and the other things that we do throughout the year.
Super. Thank you. So I wanted to ask a quick question of the attorneys, Thom and Marcus, about the committee structure there at the Medical Society. You guys have several committees, and I guess among the most focused on by a lot of folks are disciplinary, licensing, and policy. Can you tell us what those 3 committees focus on? And if you've been meeting virtually, can you talk a little bit about how the virtual aspect has made those committees function differently?
Well, this is Thom. So thank you, Franklin, for that question. There are 3 what I think of as kind of the core committees at the board. There's the disciplinary committee, which Dr. Murphy currently sits on and has chaired in the past. Marcus Jimison, our senior board attorney, who's with us today, and the other attorneys sit in that committee. Staff develop recommendations for the board regarding the things that are investigated. And the great majority of complaints and other kinds of reports that come to the board's attention about allegations of misconduct or poor care by our licensees are funneled through that disciplinary committee, where you've got 7 of the 13 board members sitting and making decisions about a recommendation to the full board about what to do regarding those cases. You know, the other big piece of what the board does is, of course, deciding who gets licensed in the first place. So the licensing committee is the other core mission committee that functions similarly to the disciplinary committee, but that's all about whether someone's going to get a license in the first place. The gigantic supermajority of applications we get are contain no red flags, no problems. Staff issues those licenses, but there are a small number that come through that licensing committee for consideration, and Marcus and the other attorneys and the physicians and physician assistant on staff look at those and help make recommendations to the committee, who ultimately decide what to recommend to the full board about giving the license. Todd Brocious is one of the other senior board attorneys. He's not on this call with us today, but he staffs the policy committee. They don't look at cases. That's not about whether someone gets a license or loses their license. It's about guidance that the board might issue to help its licensees do the right thing, stay in the safe space in order to do their jobs freely and joyfully and free of interference by the medical board.
Super. And so the second part of that question, maybe Marcus, you could take a stab at it in terms of what you used to do. I think with your committees, you meet in person, and now perhaps you're having to do, like everyone else is doing, meet virtually. Can you talk about that a bit?
I'll be happy to, and again, thank you for the invitation, and it's really nice to be part of this. We have not met virtually yet. Our last board meeting was in March, right before all the shelter-in-place orders went into effect. We had a very limited meeting. It was over a day and a half. We had a very streamlined agenda. And after that meeting, we don't meet again until later this month, around May 20th. We are going to do that virtually. A lot of work by the staff has already taken place to set up multiple virtual meetings with all the committees. We have a challenge in that many of the things that the board talks about during our meetings is what we call in closed session. So we have to jump between open session items and closed session, meaning we have to set up multiple meetings for everybody coming in remotely. So we have to dial in, hang up, and then dial in again. But our first virtual meeting will be this month, and we'll see how it goes.
Yeah. Quick follow-up on the licensing, and Thom, I want to come back to you. Typically, if a provider comes into the state and applies for license in North Carolina, about how long does that take, that process to be approved?
Well, that depends kind of in light of what I said a little bit earlier. If a case is going to go to the licensing committee, then it's going to take a little while. But as I said, a vast majority of all the applications we get, we process about 2,500 applications for licensure a year, and the great majority of those are complete, contain everything the board needs to make a decision on a license. There's no indication of any matters that require follow-up. It's an online process. We've been able to survive during this pandemic. Marcus didn't mention that we've had several special or emergency meetings, and we were able to do that virtually because we have good technology. So in the hard times, the technology is helping us out, and the normal times, our technology and our staff are able to turn around license applications very quickly. Once the license application is complete, this is a little bit of a dangerous statement for me because I haven't asked this question of the licensing manager lately, but once the application is complete, the staff turns those around in a couple of days. Now, the process of getting all the pieces into the board takes a few weeks, but I think start to finish, applicants routinely begin the application and get their license without any of the additional steps of going through the licensing committee within a few weeks.
And if I could,
pretty swift.
Yeah. If I could add a quick comment on too, and just really say that, give great kudos to the licensing committee, because in addition to that work that they do on a normal basis, this is normally the busy time of the year. As you can imagine, residents coming into the state to start their residencies and fellowships, and new licensees wanting to come in kind of for a July, August kind of start time frame. The license committee is able to work through that, given some of the challenges that we described, new processes, working at home, but also with some of the other license and special things that we've done that I'm sure we'll get to a little bit later. So just want to say that given the sheer volume of work that they have had to do, I think they've done a great job in kind of moving things forward through the system as Mr. Mansfield described.
Super. Thank you. Evelyn, I want to get you involved now as the Chief Communications Officer for the board. You're responsible for messaging to stakeholders. How has that changed your message over time of COVID-19?
So thank you so much for the opportunity to take this question. You know, we've been very intentional over the years to develop relationships with member organizations like the Medical Society and a bunch of other stakeholders. And in regular times, those are primarily used to get information out to licensees in a way that is more than just expanding our own direct communication channel. But during COVID-19, the message hasn't changed. It's really the frequency that has increased. So if you recall back in March, when things were changing so quickly, it seemed like every day there was something new coming in, new information. We were fielding a lot of requests from a lot of different stakeholders, and it was apparent that we were going to need to take action before the next board meeting. So we knew we were going to have to call a series of special meetings. And so we intentionally ramped up communication, one, to let folks know what we're working on, to get feedback, but also to ask for input on what can we do to help. Is this something that would help your members? What are you hearing on the front lines? What are your members saying? And so that communication channel really was helpful so that we could have up-to-date information. It helped us to prioritize what was going to have the best impact as we were working to remove some of the barriers that were needed so that the physicians and PAs in our state could effectively respond to the crisis. And we really wanted to make sure no one was left in the dark. So within hours or sometimes minutes of a meeting, we were able to push out information. These are the actions that the board has now taken, with links to the actual orders or rules, and then keeping track of everything in one document so that people could use it as a reference in case they had questions from their members or whatnot. So the message hasn't changed. It's really amplifying the message and strengthening those relationships that were already in place so that people could come to us with questions and requests and get the latest information.
Right. And you mentioned, Evelyn, that the traffic, I will call it the traffic, of your communications from your stakeholders has increased over the COVID-19. And I imagine you're getting those both via telephone and maybe some questions through your web and email. How much has it increased? 2, 3, 4-fold?
Well, we've got a lot of different folks who field calls. So the calls from, I would say the historic calls that we were taking on subjects prior to the pandemic have slowed down in some regard. And calls for new information from patients, telling us about, do I have to go into the doctor's office? They're telling me I have to go in. Can I use telemedicine? How do I use telemedicine? Those kinds of calls have gone up. But we also have a wide number of people that are taking different types of calls. So it's, there's been some increase. I couldn't tell you exactly how much it is, but I would say that the day-to-day communication, I know I'm in regular contact with a lot of the member associations much more frequently, just on a one-to-one basis. And so I couldn't put a specific number on it, but I definitely spend a lot more time on the phone and email correspondence and in meetings than I was prior to the pandemic.
Yeah, sure. And I know that your constituents are sometimes, people think that the medical board is just a place for doctors to be licensed and then have their complaints registered, but you do a lot of things for the consumers, the patients out there. And can Dr. Bryant, can you expound on that a little bit, what you do for the patients of North Carolina?
Well, as I said, not only for the licensees are we a resource, but also for the consumers. We actually, as part of our organizational structure, one thing that didn't get mentioned was our outreach committee. And so that committee is charged with increasing the visibility of the medical board, not only to the licensees, but also to the consumers and the public. And we have various methods of doing that through surveys where we will actually go out through that department and through Ms. Contre's office and actually go out and assess and see what the need of consumers are. We've had things in the past called, there's actually a section on the website where you can look up a licensee. So initiatives such as Know Your Doctor. So go and look up your licensee to see what services they provide. We also, for the licensees, encourage them to go on the website and actually update their profiles and put pertinent information that may be helpful if you have a particular licensee that's looking for maybe a specific type of professional or a professional that speaks a certain language or accepts a certain type of insurance or has a specific interest. So we do a lot through the outreach committee and just through our overall platform to increase our availability and usefulness to consumers of the state.
And if I could just tag on to that real quick, Franklin, I like to call the calls that the communications department takes are what I call the non-complaint complaint calls. So these are calls from, oftentimes from patients who have a question. They want to know, well, what's the rule on this, or what's the law on this, or why was I told this? And so we try to be a trusted, unbiased resource for the patients in our state, and also for licensees. They'll call us up and say, hey, I need to understand, I have this question on the STOP Act, or, I have this situation with a patient. How should I handle that in terms of, they want some, I can't say advice, but they want to be directed to where to find the policy statements that we have that are there to serve as a resource for licensees as well. So our department really tries to be a trusted resource for the people of our state.
Hey,
yeah, well, let me say this. Go ahead. I'm sorry.
Hey, Franklin, this is Thom. Yeah, if I might just tag on to that too.
Sure.
I was listening to Evelyn talk and thinking about sort of how day-to-day life goes for Marcus and me and the other attorneys whose offices are near the communications department. And we get into conversations with those folks quite often about these calls that Evelyn's describing getting from the patients in North Carolina. And sometimes it's sort of, what can I say in this situation? I'm really proud, of the things that Dr. Murphy described, and I'm really proud of what our communications department does as kind of the liaison between the board and the public. And what I'd like the Medical Society's members to know about that is Evelyn and her staff are doing what she described. They're giving those callers an unbiased response to their question, and there's so many times that a patient or a family member of a patient's calling in, they're confused, they're frustrated, they're upset. And rather than filing a complaint against the licensee, they get some information. Evelyn and her staff aren't trying to steer anybody in any particular direction, but once we give them some information and listen to them, they go away. They might not be happy, but they aren't as upset as they were before. Sometimes they go away satisfied. And so it's a great service to the public. It's also a great service to our licensees because we sort out a lot of issues that way that might otherwise result in a complaint being filed that didn't need to be filed.
And Thom, let me add the North Carolina Medical Society's stance on that, because I know I get a lot of calls and emails sent to me at the Medical Society, and a lot of times we can't answer them, and we refer them to the medical board. And I've done a lot of work with you guys, particularly on some of the office closure stuff and some of your STOP Act stuff, and have always found you guys to be a very trusted resource that we feel very comfortable referring our members and or patients that might call us to you guys. So we appreciate that. I know that the medical board has taken several steps to be more flexible and responsive during this time of COVID-19. So I want to delve into that a little bit in a couple of areas. So Marcus, what have you all done to reduce the barriers to licensure in the state during this time?
Thank you again for the question. A lot of credit has to be given to Dr. Murphy and the board members. As Thom and Evelyn described, we had a series of special meetings after the state of emergency was declared, and Dr. Murphy called special meeting after special meeting to to do a lot of things that I think we'll probably end up discussing later. But specifically, we, as Evelyn and Thom mentioned, we were getting phone calls from a lot of hospitals. And the hospitals were planning for the worst. They were looking to help with possible healthcare shortages, provider shortages, and to be able to move providers around from one place to the other place. When you move advanced practice practitioners around from one place to the other place, there's certain regulatory requirements. Nurse practitioners and PAs have to have supervising positions. They have to document that with the boards, and there's other regulatory requirements about written scope of practice documents and so forth. There were also the issue of new graduates, new PA graduates and new nurse practitioner graduates who will be unable to take their certification exams because testing centers were being closed. Because testing centers were closed, they couldn't finish the licensure requirements that are typically in place before a pandemic hits. So specifically, we have issued orders, several orders regarding licensing of new graduates who are unable to take their certification exams. We helped alleviate the burdens of reassigning advanced practice practitioners from one area of a facility to another area of a facility. And we also made it easier for doctors who have inactive licenses who want to help out. There are doctors who have retired, they allow their licenses to go inactive, and they want to help out during this pandemic. And we created a streamlined system for them. And that allows me to say one thing I want to say before this conversation ends. For all the healthcare providers, Dr. Murphy, and all you other healthcare providers who are doing what you're doing day in and day out, you certainly have the appreciation of me and everyone in the state and everyone at the medical board. What you're doing is truly, truly heroic.
And I would second that last statement. As a follow-up, Marcus, I know that in regarding APPs, there is a certain geographic requirement in terms of supervision. Have you all relaxed that, or have you thought about relaxing that a bit because of the COVID-19 pandemic?
The board historically has not put a strict geographic limit on the supervision of APPs. We allow a lot of flexibility with that, and that's historically what we have done. In regards to specifically during this emergency, the board and the legislature have helped relax the documentation of certain supervisory acts. However, it's still the expectation of the medical board that APPs be supervised and that supervision be meaningful. Meaningful supervision means having access to a doctor either in person or electronically should medical issues arise so that the APP can get the help immediately. That has not been relaxed. However, we're starting to emphasize that more and more as APPs are reassigned and maybe doing tasks that they haven't done before in a long time.
Okay, thanks. I believe Tina might have a couple of questions from the chat. Tina?
Yeah, I think Aubrey is managing the chat, but I'm going to jump in and actually ask you a question about complaints. It was something that I think you were talking about that spurred me to think about this. And I was thinking, has the, I guess it's for the attorneys on the call, Marcus and Thom, do you, how has the pandemic impacted any ongoing investigations? Like anything that's, or issues or any disciplinary actions that were underway? How has the pandemic or social distancing and everything that's happened impacted that work? if at all?
Thanks for the question, Tina. This is Thom. Like every other organization, we've had to figure out how to get our work done with all the considerations present now that weren't present back in the first part of this year in North Carolina and in Raleigh. We have about 11 investigators who are stationed out around the state. So when we conduct field investigations, we have a professional, highly trained, highly experienced investigator who goes out and visits with our licensees and other potential witnesses in cases. They gather documents, they take statements from witnesses, and that's been a little bit harder to do. So we have to rely more on technology, emailing, asking for a document, talking to folks on the phone, doing Zoom interviews of people, that sort of thing. At our office in Raleigh, we've been able to do business as usual more than some folks can and more than we can in our field investigations. We do have kind of a skeleton staff who are in the office part of the time, and we're getting in voluminous medical records. Our process for investigating a quality of care case, for instance, is to get all the relevant medical records. We get those reviewed by our in-house medical staff. We use outside community-based specialists in the area of care to look at the cases. We can do all that through email and transferring files around and that sort of thing. So, as Marcus described, we had a shortened meeting that was mostly in person in March. We are going to have, as he said, our first entirely virtual meeting next week. So those 7 members of the disciplinary committee will see work product that looks mostly like what they saw in March and in January and other past meetings. And they will talk to one another like we're talking to each other now, and spend 4 hours next Wednesday morning going through these cases and talking about them and deciding what they want to recommend to the full board. We've, through technology and the diligence of the staff and the dedication of the board members, we've been able to work around the limitations.
Pretty much on track then in terms of time.
If I may also add one thing about how our investigations have changed. Now, as Thom said, do we have investigators who are basically doing all of their interviews remotely now, either through Zoom or MS Teams or just over the telephone. But part of our investigative tools is that we order people for assessments if we think they have an alcohol problem or some other medical condition that's impairing their ability to practice safely. We order folks for examinations and assessments. Those orders have been issued with the stipulation that if the licensee feels it's unsafe to travel or unsafe to present to an assessment, then let us know and we'll make accommodations to reschedule those assessments. So we're trying to respect, all the restrictions that have been placed on people being able to do things and to travel. A lot of assessment centers around the state. A lot of assessments are overnight for 4 days. And so we're making arrangements, and several have been postponed because of that.
Changing a little bit, but it made me think about restrictions, right? So I'm thinking, we've talked with a lot of people who say that they have, face many challenges when it comes to treating patients with chronic disease and under this pandemic. So I was wondering, if there's a complaint of any sort, would you, as a medical board, take into consideration these difficulties as well?
Tina, that's a good question. I'll take that one. Historically, pre-pandemic, the board has always looked at all the circumstances present in any case it's investigated and it's considering. So the board expects physicians to always do their best. Physicians are smart, well-trained, dedicated people who put their patients' interests ahead of their own, and they try very hard. And the board, 10 of the 13 members are medical practitioners. We have 1 physician assistant, 1 nurse practitioner, 3 public members, and all the rest, like Dr. Murphy, are physicians. So these are the folks looking at those cases, and while the standard of care might not change and how care is delivered, circumstances do. And it's the board will pay attention to what was going on at the time and place. And if you're talking about a physician or a PA who's slugging it out on the front lines in a COVID-19 situation, then that's going to be part of the calculus that the board applies to evaluating that care.
And if I may say too, from my time as the president, but also sitting on those committees, specifically the disciplinary committee, the discussions are very robust. We take, everything from the full investigations, and the staff is very humble, but the investigators do an extremely thorough job of investigating to get to not only the bigger issues that you may look at with the medical records and those things, but some of the more subtle issues that may be going on in the office, in the community, things like that. So we do have access to all of that information and take all that into consideration. As Mr. Mansfield said, we obviously expect that the care that's given meets the standard of care, but we do realize that there is a context in which this care occurs, and you can't really separate the two out.
Okay. Due to COVID-19, telemedicine has just exploded all over the place. So this is going to be a question that I want everybody to take a whack at, because I think it'll be a little bit different, of course, from the physician perspective, the legal perspective, and then the communication folks. But I want to know what you guys have changed as a result of maybe policy and what you're seeing and what kind of complaints or questions. So there's a lot to unpack there. So I'm afraid I'm going to have to ask you, Dr. Murphy, to take that first one.
Sure, yeah. I'll start and then let everybody else kind of fill in. But it just goes back to what I said in my previous comment, that we do expect that there is a certain standard that is applied when you're taking care of patients. So whether that be in the office, via telemedicine. And we also realize that there are a lot of different platforms for delivering that care. Different methods of telemedicine that come before us just on a daily basis, and we have to realize how we want to deal with those. So even without the current situation, the issue of telemedicine is a complicated one that we deal with a lot, but obviously a very important way of delivering care. But as I said before, although the standard of care doesn't change, the context does. And so it's important as we look at these cases to realize that even if the care was done via telephone, via video, via Skype, were the essential elements that need to be taken care of with regards to patient care and the doctor-physician, the patient-physician, the licensee, patient, were the essential elements of that relationship preserved. And so that's what we really look towards in those situations. And I'll pass it off to Mr. Mansfield also to add some more details.
I'd like to lateral to Ms. Contre for a response on that if she's ready. I'd like to hear about what the communications department has done in responding to questions about telemedicine.
Sure. So, back in the early days of the pandemic, we started a resource page to begin to have one spot where we could provide answers, FAQs, information, guidance, whatnot, on some of the questions that we were getting, and telemedicine was certainly part of it. So, the use of telemedicine, our policy really has not changed. Regardless of what platform, what means for delivering care, a licensee needs to be able to deliver care effectively in whatever the encounter entails. So if they can't give an appropriate physical exam because they're doing this through video, then that would dictate what they're able to do. What are the limitations of telemedicine? Federal guidelines have changed around prescribing, but that is really not what we have changed. The venues are really where it has changed, and so we have some guidance on our website about recognizing that the standards of care in a pandemic may change, and the necessity to triage and manage limited resources that has changed during this pandemic. But we really want folks to understand that our primary focus is on patient safety. So that is one component of this. We've received calls from patients who their doctor maybe is not delivering telemedicine and they would really like to do that, or maybe they were allowing FaceTime visits. And early in the pandemic, I just got off the phone before this webinar talking to a patient care, a family member whose elderly father was using telemedicine effectively with the doctor, but then suddenly they stopped. And so I had to explain to them that we can't make a doctor or a PA use telemedicine. They have guidelines that they have to follow, and if they feel like they're not effectively seeing the patient, treating the patient, then they need to use their good judgment. I wanted to bring this up for the purposes of the audience. A couple years ago, we did a survey of our licensees and asked them questions about telemedicine. So we wanted to know how many people are using telemedicine, how many are interested in telemedicine, and how many were not considering it at all. So of the people that we surveyed, 14% said yes, they were using it, and of those who used it, they really liked it. 21% were considering it, but they just hadn't quite gotten over the hump on implementing it in their practice. And 64% said, no way, no how, we're not even considering this. So I think if we were to do that survey again and ask those same questions, I think those percentages might be flipped. Because a lot has changed that's outside of the board's control. How much are payers paying? What are they able to do with telemedicine? A lot of the context around telemedicine has changed, but our policies have not.
Well, before we get into the legal guys answering that question, I did want to give you, Evelyn, some feedback. Medical Society, DHHS, and some other organizations have been surveying primary care practices across the state, and you are correct. Those percentages actually are upside down from where they were in the past. It's been driven by this pandemic, so it's really been interesting to see that change come into place. So, Marcus, did you want to take a whack at the telemedicine question from the legal perspective?
I think we have not seen a lot of cases or complaints involving telemedicine, but I think Dr. Murphy hit it right on the nail, hit the nail right on the head, where when he said that the board evaluates telemedicine cases exactly how they would do any other case to make sure the standard of care is met. And the board's position statement is pretty direct in that the standard of care is what the patient needs and not dependent upon whether the care happens in person or over Skype or over the telephone.
Right. We know that several medications have been touted in the media as effectively being a great treatment for COVID-19. And I'd like to get into what actions the board has taken to curb maybe the end of some of these medications. So I want to start again with Dr. Bryant, please.
So thank you for bringing this up. As you know, that the specific questions regarding medicines used to treat COVID-19 have been widely touted earlier in the news. And obviously those medications have, benefits, side effects, are used for other conditions. And so we actually received some correspondence from Secretary Cohen's office about ways to deal with that. And Thom was one of the major authors in helping us to navigate that. So I'll let Thom give the detailed analysis of how we responded to those questions and what we came up with.
Super.
Thank you, Dr. Murphy, and thank you, Franklin. So I think that's a really good example of how we've collaborated with other parts of government and also organized medicine generally. The board has been engaged in numerous conversations and meetings and discussions about how to craft responses, whether we were being asked to contribute to things that were going into executive orders of the governor, a lot of the time we were talking to folks at DHHS about things that would end up being in an executive order, and Secretary Cohen did specifically ask for the board to look at this and to take an action because of the problems. So our ability to have a meaningful conversation was because of those relationships and because of the conversations and the ability to collaborate with the other folks and to do it in a way that was responsive, and the board demonstrated flexibility. But one thing that's I think is really important to say today, and relative to a lot of this conversation, is that the board is in an interesting spot. It has an interesting job. Its job is to protect patients. Of course, Dr. Murphy in his going on 6 years at the board has always been an advocate for the board striking a balance, finding that sweet spot between being flexible but always protecting patients by paying attention to what's going on the ground and being realistic. And but the board from time to time, when in the beginning, in preparing for this, I was thinking, our emotional states were very different back in early March. Everybody was in these a million breathless conversations about this thing that was coming that we couldn't quite get our arms around yet. We know a lot more now than we did then. So in the midst of those breathless conversations where everybody's trying to ramp up at light speed to get ready for the tsunami of COVID-19 patients, that when you get a request that says, hey, medical board, will you do something about the problem with physicians prescribing to themselves, to their family, stockpiling hydrochloroquine and other drugs, it was important that the board paused for a second without being obstructionist. Our mantra was always, we want to assist and not to obstruct. But we asked, can we pause here and gather a little data? And so before the board acted to take action to prevent physicians prescribing to themselves and their families and stockpiling drugs that other patients need and that for some folks would not be safe, we stopped and gathered the data to make sure there was really a problem. And that process occurred over and over in the last couple of months, which is, we show up, we are present, we want to be helpful, we don't ever want to be a drag on making the changes that are necessary, but at the same time we want to make the board wants to make evidence-based decisions about what to do in the pandemic, and that's what happened in that case.
I would like to hear from Evelyn on this because of all the communication that is around this stuff.
Sure. So, we have typically not been in the habit of telling doctors and PAs and prescribers how to treat a particular illness. But, as Thom said, when we receive this request, we want to be helpful. We want to do everything we can to remove the barriers so that the people who are on the front lines have the flexibility that they need in order to, safely treat the patients who are affected by this. We do also, it is part of our job to make sure that we are cool-headed, remaining cool-headed and calm about the actions that are being taken. And so, this, at the time, this was a drug that was being touted as, the first breakthrough. And, but the reality is the testing wasn't there and the science wasn't there. But when we asked for the information and we saw that the prescriptions in North Carolina, not just nationally, but in North Carolina had increased by hundreds of percent, we knew that there was a problem. And so the communication there is, we use your judgment. We actually started with a letter from Dr. Murphy asking, doctors and PAs to use your good judgment, rely on your training and your education, and let's not fall into this situation where you're prescribing to yourself out of fear, prescribing to family out of fear. And because we felt like if we gave a reminder that, this is, we all have to keep our heads about us, our wits about us, that would be a good first step. But this was a scenario where reminding people, gently reminding them of their training and the limitations to prescribing wasn't going to be enough. And so by the time it got to the point where we needed to adopt these rules, the message that we wanted to send is, this is not a proven treatment. You need to make sure that you are not taking an unsafe step with your patients or with your family members out of that fear. And so we spent a lot of time communicating with the medical society and other member associations and other agencies. Malpractice carriers are included in our group, our stakeholder group, to help get the word out, because it was probably a small portion of prescribers that were doing this. But we have to make sure, we don't know who they are, and so we have to make sure we blanket the communication so that everybody receives the message. It's so hard to get through in a chaos. It's just breaking through the noise is a real challenge. So that was one of the things that we did.
Yeah, thank you guys. Tina, I believe you have a question.
Yeah, I have a question. Speaking of drugs and speaking of partnerships, and I know how great you are in terms of fostering and promoting these relationships that you have with different stakeholders. Are you partnering with the North Carolina Pharmacy Board at all in terms of prescribing drugs for COVID-19?
You mean partnering with them about communication efforts, or taking a look at issues around prescribing?
I think both, actually, to your point. So both about communication and both actually prescribing directions. Is there any partnership with them, or are they also part of this, conveying the message that you were referring to before?
Sure. So we have a great relationship with the Board of Pharmacy. We frequently will reach out to Jay Campbell, who's their executive director, and others at the organization to find out, what are you hearing from your pharmacists? Here's something that we're looking at. What are you seeing? Those types of conversations go on anyway. During a pandemic, they certainly go on more frequently. So, this was, I think the pharmacy board jumped on the prescribing rules right away for clear reasons, because their pharmacists are the ones that are filling these prescriptions. But we will regularly run information by them to make sure that when it comes to these types of messages, we are being accurate and we are reflecting what's happening on the ground. That's
a really good way of describing that, because the relationship with that board in particular has been a great one, and we've collaborated frequently on several issues. But as Evelyn said at the very beginning, we tried very hard, not only with this issue, but just to not be prescriptive to the physicians. Obviously, we have guidelines and standards, but have been careful throughout the years to not be excessively prescriptive when we give advice and guidance to our licensees.
I think I was also thinking about how important, and you're, I think, exemplifying that, how important it is that there is a unified message and a unified communication around this big issue. So I think I was thinking about that, Evelyn, when you were talking about, how hard it is to get through the noise, because obviously it is, right? So, but that consistency and that clarity, and then, with those different stakeholders involved, having the same message, I think is so important. Thank you, Franklin. That took a little bit more time, but thank you.
No, it's fine, thanks. Okay, we're approaching our ending time, but I want to get in a couple of questions here. So the state's at a point that we're starting to reopen things on a phased basis, and I'm sure a lot of folks are clamoring to, get back out and maybe see their physicians in person more than via telemedicine. So I want to ask all of you guys, how do you see the board going through maybe these phases? Are there things that you're anticipating that you're going to have to change or be aware of? Any problems there, etc.? Let me start maybe with Thom.
Well, thank you, Franklin, for the question. I'm not 100% sure what you're thinking of when you ask the question. For us, a lot of that is just internally how we get business done. We are trying to make accommodations and give our licensees a little bit of extra space and time to do what they need to do when they're faced with all kinds of challenges out there on the ground in their communities. Yeah, I mean, one thing is we're having this virtual meeting next week that we've been talking about, our regularly scheduled May board meeting, which is different than the several special and emergency meetings we've had. And as we said, this will be our first entirely virtual meeting. And part of our regular scheduled meetings is the board inviting licensees or applicants to come in to the board's office and sit in a conference room with about 2 or 3 board members and some staff, and to answer some questions about an application they might be making or a case that's being investigated. And we're going to conduct some of those interviews the way we're having our meeting today, using a different platform and employing some very careful safeguards. Marcus was alluding to those earlier. So, are there things we've learned from this experience that we can implement going forward? I mean, maybe there are times when someone, a physician or an applicant for a license, maybe they could avoid traveling to Raleigh for that interview. Maybe we would do more virtual interviews like this. Certainly it goes to generally how the board gets its work done. I think for the most part, well, first of all, I don't think we're ever going to go back to normal. It's not ever going to be the way it was before. But to the extent we're getting back to normal, I think that our board meetings will continue to be mostly like they've been. I think it's really important for our 13 board members to come in. They're coming in from all over the state. Getting those folks in the room together in the same space, looking at each other, talking about these cases, talking about policies through the policy committee, doing the executive committee work that Dr. Murphy leads as our president. It's just important to do that stuff in person. So I think we'll mostly get back to the way we were doing it before. I think the other question you asked about telemedicine and how is that different now than it was before, I think probably from a regulatory standpoint, we're going to see some shift out there on the ground, and we'll see how that plays out in terms of things that come to the board's attention.
I wanted to let Dr. Murphy, as the practicing physician on the panel, talk a little bit about these next phases, maybe how he might see those.
Right, and from where I sit, kind of here on what I say, pretty close to the front lines, and dealing with patient care every day. I think that just from our perspective as providers, it's going to be a kind of a slow move back to not the normal we had before, but something different, something that maybe encompasses more use of things like telemedicine. Things that will encompass maybe care delivery in ways that we hadn't contemplated or have not contemplated. I do know that in my conversations with my colleagues here, in my specialty, also in other specialties, and across the country, we are just talking about how can we, reopen very thoughtfully. How can we reopen very deliberately, but most importantly is how do we do that in a data-driven fashion. And so as Ms. Contre mentioned, it's very important that we sometimes find a way to get through some of the noise associated with this, but do it with a very thoughtful, patient-centered approach that takes patient safety at its core. And I think that we need to be prepared for just a slow, steady growth with maybe a few steps backwards for every few steps forward to get back to a way of delivering healthcare to all the citizens that need it.
And if I could jump in, Franklin, I had a couple things to say about that. One is, my department receives calls from patients that have had an interaction at their doctor's office that they were uncomfortable with. So maybe there isn't a separate waiting room. The waiting room is full and people aren't wearing masks, or there doesn't appear to be any sanitizing going on and that sort of thing. I think a vast majority of doctors and PAs and other healthcare providers in our state are doing a great job, a fantastic job. I think it's really important to remember that every patient that comes in is going to have a different level of comfort. So you're going to have some patients who feel comfortable going back to normal, and you're going to have some patients who have a little bit of fear. Maybe they have a reason for that. Maybe they've got somebody at home that they're worried about. Maybe they have an underlying condition. And so, you know, using good judgment, following guidelines, keeping patients comfortable, but also thinking, you know, once we're through at least this wave, think about how you can improve your office practices for the next time, whether it's the next wave or the next pandemic. What are the things that you can do to, you know, take advantage of the learning curve that we've all just been through, so that if it does come back in the fall, for example, you won't have as much of a delay between what your regular operations and the you know, the pandemic operations, because I think that there's a real benefit to making sure we are better at this next time.
Totally agree. Chyna, do you have a question?
I do. I have a question from the audience, and I can't. I so agree. The learning, I think, is going to be fundamental. That we really take this on board and see what we can do to improve and better ourselves and be prepared. So here's a question for our audience. It says, if a patient comes from South Carolina to see me in North Carolina, am I covered to do a telehealth visit in South Carolina since I'm not licensed in that state?
So that's a question about South Carolina law that I don't know the answer to. Marcus or maybe Evelyn, you've heard something about this, or Dr. Murphy. I'm not sure how South Carolina is handling that, because that would be if the physician is in North Carolina taking care of a South Carolina resident, that's not going to be a function of North Carolina law. The North Carolina Medical Board won't be concerned with that licensure question, but the South Carolina Board could.
So nearly all states require a doctor or PA to be licensed in that state in order to see a patient who is physically in that state. During a state of emergency, those laws may have been relaxed to allow any doctor or PA who has an active license in another state to come in. So my advice would be to look at the South Carolina State Medical Board's website to see if there's any information about their licensure requirements during a state of emergency.
And would this
I would
be
agree with that.
For any out-of-state patient then? That's kind of like the same thing that you would recommend?
So Tina, if I may double dip, what I would say, I hope these other states have done what the North Carolina Medical Board has done, which is create a limited emergency license, which is an online application that takes about 5 minutes and it's free. So we think it's important for doctors practicing into North Carolina by telemedicine to be tracked by the North Carolina Medical Board. I hope that's what's going on in other states. Some other states have done that, but it's going to vary from state to state.
If I can add, the vast majority of our temporary limited emergency licenses is from applicants wanting to do telemedicine.
And we've issued over 1,000 of those.
Wow.
Is there a link for that we can post for our audience, or I can just go on the medical board website and find it perhaps?
About the limited emergency license?
Mm-hmm.
You can go to www.ncmedboard.org/COVID, and there you'll see all of our actions around licensure, telemedicine. Thank you very much, Aubrey, for posting that so quickly. On the spot.
I was trying, but I gave up. Clearly, the lineage is my age. Thank you so much.
Okay. Well, listen, guys, it's right about the top of the hour, so we're going to land the plane. I want to thank the panelists today. Have been super, and put in another plug for the North Carolina Medical Board, who we at the Medical Society work with almost on a weekly, daily basis. And you guys have been great source of information, and thank you for your time today. Tina?
Thank you for having us.
Thank you so much.
Oh, you're welcome.
Thank you.
Thank you all so much. I can't thank you enough for taking the time today. Thank you.
Yep.
Everybody be safe.
Be safe. Be well.
Absolutely.